proceeding next with our next panelist, Dr. Ashik Imran. And he was a former assistant chief resident of internal medicine, Mount Sinai, South Nassau. And he is currently a hospitalist of Mount Sinai, South Nassau. And incoming endocrinology fellow, Brookdale University Hospital Medical Center. Dr. Ashik Imran Bhaiya, please take the floor and share your valuable advices with us.
Assalamu alaikum, everyone. Can you hear me? Okay. So again, my name is Ashik, and I would like to thank Masood Bhai for the invitation. I'm happy to be here. And thanks for the introduction, Rahana. And that was nice. Somebody. So I first would like to congratulate the incoming PGY1s. You finally on the first step of going forward, and it's a great academic achievement. Whoever seeing it right now or will see it later, I hope the discussions, whatever we are discussing, will be very helpful to you going forward. And also, I was listening to the presenters, Dr. Malik and Dr. Akhtar. I wish I had the similar kind of advice when I started my PGY1. There are little things that is very important, I thought. So I hope it helps. So I don't have any PowerPoint. I'll just try to make it conversational. If you have any questions, don't feel shy to ask any questions, Dr. Akhtar, the last thing that she said, I'm going to say this again, that you are never alone. You will have lots of support around you during this wonderful journey. And I feel like, this is US, there are lots of hospitals, universities. As you move forward, you will learn a lot of things. You will interact with a lot of patients and a lot of attendings around, and a lot of consultants. You will learn a lot. You will do research presentations, and you will advance to fellowship hospitalists. I'm so proud of you. I can see you all like working in different roles in different health sector, and it'll be great for the community and for all the patients and for the US. So I try to write some points what I can talk about. So again, the PGY1s, we all came from Bangladesh and other countries that if you are, and we waited for this journey to start. And this is the time when we finally, reached our dream. We're starting our PGY1. It feels good. So enjoy that moment. This is the time that you really can enjoy. You don't have residency started yet, so prepare for that little bit for the ride. When I say like prepare means, so we match to different kind of hospitals, right? Some may be in different states, some may be in different places, some may be in the same, not in the same location that I'm right now. Some of us are married, some of us are not. Somebody was physicians back in Bangladesh, somebody are not physicians, right? So preparation is individualized. Different people need different kind of preparation. While you're enjoying this time, prepare means, try when the residency starts, the internship can be draining because long hours, hard working, you will be tired. And it's almost like when you are working in the inpatient, IM, family medicine, surgery, whatever you do, it can be very draining, and you have to be there for like 6 days a week. You have to wait for the golden weekend. So it's better to be ready for that start from July 1st. So have a place within 15 minutes radius to that place where you go to, if you can. And then if you have kids, try to have support at home so that, somebody can help you with the kids, because when you're in the hospital, you may not be able to even look at your phone. So it may be very difficult. Like little things we tried, me and my wife, we both were here. So we try to have webcam, we tried our family members, or, if you can afford nanny for a few hours, and then take turns with your spouse. So those would be helpful. And then when you go to start your residency, internship, before starting, there will be lots of orientation from human resource, your upper classes. They will try to help. Everybody is very helpful here. So, but for you, as we said, like a lot of us different backgrounds, many of us have more medical knowledge. Maybe some PGY1s will be actually more knowledgeable than the PGY2s. Somebody may be younger, they may know how to navigate the EMR better. But different hospital, different EMR, and you will learn them, know the system, know the system, know the EMR, know the hospital, geography. And then once we start, initially, so when we the attendings, the upper class, we try to give like less patients, just to get you used to. Those who did the rotations here in the US hospitals, they are used to. The other people have seen maybe more patients, but how to document, how to do the EMR notes, how to order labs for the next days, maybe a little bit of challenge. So first few days, less patients, get used to the system, and then know how to order the labs and everything. So another thing I want to say is, if you can have the EMR on your phone as well, so you can, when you go to the patient side, bedside, you can look up the most recent labs that maybe was not during pre-round, but during the rounding, it may just pop up in your EMR. So have those things. What else? So, it depends what kind of preparation you need, because some of you will start with ICU, somebody will start in the inpatient, somebody with the specialty rotation, somebody with outpatient. So what kind of preparation? There is some general preparation, and some is like, very department wise. So I will say inpatient, initial few days, you don't have much to prepare. You have to know the system. But when you know a little bit, you can do, have a list of your patients like that you will be following, right? And then you can access the Google Drive. You can see what patients, what are the updates, what you need to follow the next day, and who are critical, not critical. So what you can do is, what I used to do is, see, when we start as an intern, right? So days can be long because hours are long. So for me, the challenge was to leave on time, right? We want to leave on time, but also that doesn't mean that we will miss something that we're supposed to do. So we need to have everything done before we leave. And there should be proper sign out as well. So what I used to do is, and I advise to all the juniors and my residents, that if you can come earlier, like whenever 6:15, 6:30, you can come in. You already know your old patients. Go and see them very quick. Speak with the nurses, from the night nurses, see if there was any overnight things happen, anything that you should be aware of. And then, so the night follow-ups almost done. So you come back, you get your new patients that are being admitted overnight. So you add them, you get your new patients. Now you can spend time on the new patients. Now you go to see the new patients, right? And then spend a little bit more time on them, and then come back. When you sit in front of the computer, now the labs are coming back, so you can see the most recent labs, and then you can write down, and then you prepare for the presentation, like rounding, right? So those are the more organized way, I think. Like, you can be a little bit more organized to have the days go smoother. Um, and like the PGY ones, as somebody said, like, it really doesn't matter how meritorious or like how high a score you had. For me, for the other residents, we all want somebody who will listen, who will be attentive, who will be sincere, hardworking, and will listen to the rounds. What orders are being given. So you have to have the ability to have the conversation, to get the information, and then transform the information into the day's work, right? Again, you are not alone. There will be a lot of help attending the upper class, the chief residents, all will help you and guide you through the process. The teamwork. Teamwork is very important. See, while we are applying for this, right? So sometimes we're a little bit selfish because we have to get in. But when you're working as a resident, it's more about teamwork. Teamwork doesn't mean only you and your class. Teamwork means you, your class, your upper class, lower class, the nursing, the social workers. Everybody is a part of teamwork. What we are trying to do is we are trying to get the patients better and get them ready to be discharged from the hospital, right? So from the beginning, like, teamwork, be nice. So you have to be like, we all have to be. So we're from Bangladesh, right? I was not a very good speaker. I'm not very well spoken, but over time you develop those things. So sometimes we are so gentle from Bangladesh. it sometimes can be assumed as weakness, right? So that has happened with me. So be humble, be confident, and so be confident, not arrogant. Be humble, but don't be weak. So those are like the things that I want to do. And then be attentive. Um, Work with your so be for the other colleague. Say um, in the initial few days or few weeks when you are on call, like the PGY ones have to be on call, right? So you have to have the pager with you. So sometimes on call, when you're feeling overwhelmed because all the other residents are signing out to you for that on-call time, and then you're also responsible for other patients, it may be overwhelming. And then you have to prepare to sign out to the night team, right? This happens with everyone. So sometimes your colleague may help you a little bit, like maybe he's signing out a little bit late, or maybe he's there for you, or she is helping you. So when your time comes, try to give it back. But also it's very important to try to learn how to live on time, because that extra hour is very important. That's what I always say. What else? Then update and improve. So first few days, maybe you are seeing one first week, maybe 4 patients, 5 patients, then go up to 6, 7, 8, and then the ACGME cutoff, I think, is 10 patients. So the 10 patients, 10 patients are a lot, because these patients can be critical, may need ICU upgrading, downgrading, maybe some needs to be discharged. So update means, you learn how to take the responsibility of 10 patients from 4 to 5. Now you are the resident. So, and whatever the attendings tell you, try to write it down. I used to forget everything. So I try to write down like small notes and then go over the things. Is everything done? If everything is done, then those things have to be transformed into my soap note. My soap note cannot be a photocopy of previous day's note. We cannot just keep it and adding lines, that it doesn't work that way. So it makes your day go faster, but that's not something that is being appreciated by others. So update, and also doing notes, you don't have to write, let's say hemoglobin is 6.7 and then it's 7, that's 2. You don't have to specify everything. You can say just hypokalemia improving, replete as PRN, like this, you can make things faster, but whatever you do, it has to be in the note. And then, so you can do those. And what else I wanted to say? So improve means, say today's first few days during the rounding, maybe the attending discusses, right? What are the labs? So it's a little bit hypokalemia, hypomagnesemia, hyponatremia. So there are some student level, now you're PGY1 level, then it's PGY2, then PGY3. Then, the attending discuss. So different levels. So first PGY1, we want you to address those things. This patient's having this, lab shows this. Again, next day when you see the hemoglobin is again anemic, it doesn't make sense, right? We want to know what is trending up or trending down. So that makes more sense. So learn how to present those things in a better way, and point those things and see how they're being managed. So if a patient has hyperkalemia, right, we all know what it is. So when we have to do EKG, when we have to do calcium gluconate, when we have to treat like hyperkalemia cocktail, then is it really hyperkalemic? Plasma potassium, breakdown of the RBC. So these will be very fast. So see how it's being managed. If you don't remember, write it in a note, a small note for you. So next time, if you're on night or on call, you see something and your upper level is doing an admission or not around, then you are not thrown out. You know what to order and how to order in the EMR. So this goes with everything, like electrolyte, labs, blood pressure is dropping. This would be a common thing. Blood pressure dropping or blood pressure going up or heart rate going up. So what is the reason? Anybody, if has pain like me, my heart rate will go up or my pulse will go up. Like Dr. Akhtar, she left, she said that somebody delirious at night, right? So these are very common complaints. Sometimes there is, maybe she's retaining urine, or maybe she did not take something for pain. There may be little things. For PGY1s, you need to go there at bedside, see the patient, examine if you have the time. If you don't have, know what to order very quick, and then see at your earliest convenience. So those are other things. This will come, this will come with training, learning. That's why the training is for us to learn how to do. So update, improve. So if the attendings, like we want to know that what we have told during the rounds, the PGY1, the students and PGY2s, they know it, they have learned, they have studied. So when I talk about this next time, they're able to say, maybe they have read about it, the case that we discussed, maybe they went home and read up to date the guidelines, and now they can incorporate into the management of the patient. That is another thing. And again, so teamwork, hard working, whatever we say during our interviews, so those it's time to show them at work. Again, this is like inpatient rotation. Some of you will start with ICU rotation. Same thing, have some preparation. Preparation means, what ICU books, like Marino's ICU book, somebody show, that's a good one. But then again, see, basic thing is ICU doesn't mean you'll have 10 patients. You'll have probably 1, 2 initially, then 3, 4, 5 maybe. It depends how many beds you have, how many people are there at that time. But whatever patients you have, know them, you have to know intensively. So we're starting ICU, it can be overwhelming. But again, if you're organized, if you have a plan, look at the videos. There are lots of YouTube good videos, how to present the case in the ICU to the attending. See, and then how to present. The ICU start very early, 8:30. So you have to go there, have your patients, get sign out from the ICU team, from night team, write it down, then write on your paper the way you want it to, like input, output, pressures, line, when the lines, write it down. And then have the printout with you. That's fine. Then when you examine the patients at bedside, look at the vent setting, ABG, all these things, Foley there, when it was placed, amount of thing, if patient is like, they will teach you, but you will write it down to present and then practice the presentation. Why he came, why he was in the ICU, what happened overnight, and anything new, and now what I'm doing, right? So if patient has been there for last few days, the ICU team already know. If it's patient overnight admission, then you have to present a little bit in more details. And then they will ask the examination, and finally the presentation. Presentation, I think Dr. Malik already said that you have to present system-wise, right? When you present in the inpatient, we present with like problem-based. And in the ICU, it's more like system-based because it's more intense. So presentation is preparation is the key. And first day you will do some effort. Remember, you may not be perfect. Nobody expects you to be perfect, but we want to see the effort that is being put in by incoming PGY1s. We all, the upper level residents, the nursing, the attendings, all we appreciate. If we see that little effort, everybody will be more encouraged to treat you more, treat you nicely, teach you more, and go from there. So at the end of first week, next week, now you have 1 week of knowledge. So you have seen that how the day goes, and then you will be able to do more. So 4 weeks you can improve. You will see after 1 week of inpatient, or 1 week of outpatient, or 1 week of ICU, you will see yourself as a new PGY1. You have that week of experience. That is huge. So those things, what else there? Grand rounds, right? Because residency is an academic training, right? ACGME accredited academic training. So we are not PA or NP. So we are residents. That means we have to learn. We are not there to be scribe or PMP. That means we will not be just following the orders. We do that, that is more important, but we have to upgrade. We have to learn new things. How we do learn? Some by ourselves, some by academic didactics, some by research, some by listening to others. So again, first few months, I really don't think that you will have time to study. It's more about surviving the first few months of internship. Once you do that, or while you do that, try to attend the conference, grand round conference. You may feel it difficult, especially when on call. It may not be even possible. But if you have the time, don't miss the EKG round. Don't miss the grand rounds. Don't miss the morning round, noon conference. All those things, mortality, morbidity conference that we have, right? There is a chance to interact with other residents, sometimes with other specialties. And that's a great way of learning. And that's one thing. Then studying. Then if you have time, initially, all the things that is discussed, write down the points, read them later, like electrolyte imbalance, anemia, whatever. Like one hyponatremia can, if you really want to learn hyponatremia, it will take you long. I read each time and I forget. Then I learn, okay, learning hyponatremia, there can be different approach, up-to-date approach, ACP approach. Like there is different ways of knowing hyponatremia, like lab-based, fluid overload-based, and then how we treat it. It's fun. The more you advance, you will see cardio saying give Lasix, and the nephro will say give fluid. The more you advance, you will see all these things. But study, and what will study? Again, Dr. Malika was very good on that on presentation. So like up to date, that's a good one, right? We can always access up to date. What I would suggest is also, I mean, not in first year, maybe after 6 months. So if you, many of you may not have taken the USMLEs, or I don't think there is any DO candidate complex. So many of the programs, they want their step 3 to be done if you have not done them already by the end of first month. Otherwise, they may not, permit you to graduate to next level. Some programs are, more reluctant. They say, okay, you can take it. So, but I think it's a good idea to have it done before the end of PGY1. So now you can focus on more on board ABIM or, ABFM, all those exams, certification exams, learn more. So try to take it, have it done. And then when you have time, try to do MaxEp questions along with your up-to-date. So MaxEp questions, I think MaxEp 19 is going on right now. So MaxEp 20. So this is my daughter with me. It's her birthday. She is coming into the grade. So MaxEp 2019, I think you will have for 2020. So when you have time, again, inpatient maybe second month or third month. So you can start system-wise, read as much as you can, look at the guidelines. You can have the guidelines in your phone, ACP guidelines, cardiology guidelines, the infectious disease guidelines. So learn about all those things. The other things is very important for US hospitals. Eliquis, Xarelto, you'll hear a lot about them. Coumadin indications and the difference between DVT, and the AFib, and then the loading dose, maintenance dose. So Xarelto is coming up with a lot of main things. So you will learn. So study. And sign out. Sign out is an important part. So when you are signing out to your colleague, remember, it's not about just signing out my unstable patient in an unstable way, not talking with the family because almost 5 o'clock, I have to leave, and just let him deal with it. Remember, you will be on call after 3 days, and he will do the same thing. So don't do that. Try to, like in our hospital, Mount St. South, now, so we did the iPass system. Some other hospital may have different thing. So main thing is, it should not be all your note in your sign out. So it's like room number, important things, they will tell you, but what things have to be seen, observed at night, what thing needs to be monitoring, what you order, but you don't have the time to see, like those things bold in the right side. And then other things, you can just say that unstable, stable patients, DNR, DNI, family, you can write something that family is cranky or whatever you want them to know, or patient is cranky, patient's daughter, you can do it. So some sign out are for the night team or the on-call person. Some sign out maybe for yourself or the person who will take over from next day. And some important things, just what we're waiting for and possible discharge date. So this way, and this is like a small sign out, important things, but when you sign out to that person, try to give him like a summarized, a very good summary, because now he or she will take over your patient and your patient is under his or her care. And the night team comes in, they don't know the patient, there will be 2 or 3% or 4% covering all the patients and doing admissions. So try to give them as well. And when you are night team, also write it down. So next day when you sign up to the morning team, you can tell them what happened overnight and what needs to be addressed in the morning. So sign out is very important. Always have some time to do the sign out. Those who your colleagues may not show the same courtesy to you when they're signing out to you, even if you do so, maybe they will say, all good, patients are good. I discharged, I spoke with all family, this is done and sign out is done in 5 minutes. And he was doing it so fast, you forgot to ask relevant questions. What happens next is once she goes, nurse calls. Doctor, so you are covering this? Yes, I'm on call. I'm covering this patient. Okay, so this patient's family is here. You said you would come and speak with them. You don't have any idea about that patient. So that's not fair to you, right? Or then the patient now, the blood pressure the patient has been hyperkalemic all day, like 5.8, it was not addressed, and now the patient is having some chest pain or something. So there are many things you can ask questions to. If you have any questions like, okay, blood pressure is low, is the patient on any kind of fluid? So if they say fluid, that means there is no contraindication for fluid. So little things you can ask questions. Initially, it will take longer, but with time, you will know how to do a good, efficient sign out fast and like efficiently. And so I think I touched most of the things. The jeopardy is another thing that I did not like. Is like jeopardy means in our hospital when somebody is sick, like we call sick day. So when somebody calls sick, somebody else has to come in, like the chief resident, Dr. Malik. I know you have to deal a lot with about all this, so we have to deal with this too. So you see, sometimes most of the residents sometimes they are not happy with the chiefs. They think chiefs making their life tough. But when you sit on that seat, you see how things go on. Now you can see everyone's problem. Many people will want to take sick days off. But then I have to fill that spot. Then who do I call? Then I have to call somebody who is available, right? Then we have to do a list. And residents who has been doing this over and over, they will complain why I am being called. So just the reason I'm saying this is just because you have sick days don't mean that you have to call sick days off. Personal day is different. You will have personal days. You have like say Eid or Puja or something you can have them in your mind. You are not doing clinic rotation. You are doing inpatient, so you need that day. You can ask ahead. But just calling sick day or not maintaining punctuality, not coming on time, that is bad. That chief residents will make a note, and that's not good. The program directors, they don't like those things. Um, I'm almost done. Sorry for taking long. Is like rapid code. They will go over all this, so I don't have to do. So whenever there is a pager, rapid or medical team, if you are a PGY1 on that day, don't wait, just run and be part of that team. You will learn everything. There will be lots of courses and lots of simulation trainings. And um, you will have to pronounce death as a PGY1 when patients expire. My suggestion is take time to pronounce death. So we had a situation in our hospital just 2 months ago where a patient was pronounced dead by the resident PGY1 family medicine center. He was not dead. So this became an issue. So the reason it can happen is because sometimes nurses they're very good. I'm telling you, they're very good. They're very good colleagues, but sometimes they do it very fast to have things done. Maybe the patient really expired or on the process. The patient is not on monitor. You just go in and the pupils are not dilated. Sometimes when I feel the pulse, I feel my pulse. Even now, I get scared when I pronounce a patient dead. If the patient has just expired, it's difficult because still warm, people are dialysis. Take your time. You take your time, see it. I recently, as an attending even, I made them do an EKG on a patient. Anyway, that was crazy. That was not needed, to be honest. But I'm saying take your time to pronounce death because you don't want an incident where the patient opened their eyes, right? But again, it's a very common thing. There will be IV infiltrations and other things, a lot of calls, know how to encounter them, how to monitor. Um, most is a big thing now, palliative. So they will ask the PGY ones to do most form if you're in New York hospital especially. So how to do the most, how to do emails, how to update. So all those things you need a witness. So those take time. Those also needs difficult conversation with the family members. Just learn how to do the goals of care, DNR, DNI, and to give any bad news if there is anything. Even a possibility of cancer can be bad news for someone who is not expecting that at that time. So know how to do these things. But initially, take the help from your upper level and the attendings to go. Don't go into this right by yourself. Few days, few weeks, you'll be good enough to go into this. And finally, as we do all these things, many of us will be overwhelmed, feel overwhelmed, may feel sad, may cry. Long days, I come early in the morning and I'm leaving late, and it's happening every day. I'm overwhelmed. But that means you are doing the right thing. That means you are learning. If you come late with a coffee from Dunkin', go around, and then you are leaving early, that means your residency is not going right way, and you're going to have difficult time when you work as an attending. Attending life will be different. So learn, spend, talk with your friends, talk with your family, spend time with them. We had also psychology, we called it Balint group in our hospital, where they would do a monthly conference with just one PGY group. Like as the PGY one, I had a lot to complain against my chief, against my PGY2, and some nursing that don't want to listen to me. They don't think me as a doctor. So, and some patients. So these things will change. But this is a way to, express your anger, frustration, that helps. But then again, when you work, be sincere. You will learn a lot, you will enjoy. And finally, when you come home, try to leave the work at hospital. You signed out, your pager is off, you signed out, that's it. When you go, you see it. Don't come back, look at the EMR. Oh my God, what is the hemoglobin? I gave blood, it's still bleeding. No, that is now your friend's responsibility, who is now doing that. You gave him sign out, good sign out. He is supposed to look at that, right? So this is the PGY one. Once you move to the later half of PGY one, things will be different, expectation will be different, PGY2 different, PGY2 hospitalist, like I did like 1 year, so incoming hospitalist, right? New hospitalist, different. 20-year, 30-year hospitalist is different. So that's it. That's my speech. I hope it helps whoever sees it later or now. Any questions?
I do have a question, but it's not related to PGY1 per se. But then, আপনি কিভাবে realize, like, how did you know that you wanted to pursue fellowship and not just go into hospitalist? Because I do hear that people say fellowship is just an upgraded version of residency, and the pay is also not that good, it's still that low, and then but then it's long hours, even more long hours, because now people are like, oh, you're done with residency, you're a fellow now, you should know these things. So how did you like decide that you wanted to go through the entire this difficult journey again, and how did you choose your specialty?
So after doing, in a brief, after doing 1 year of hospitalist, there are certain things that I like. There are certain things I did not like. All of us have different personality, but certain things I didn't. I feel like as a primary in the inpatient, like a lot of things I feel like are being dumped onto the primary care, especially the specialists. They give the recommended beautiful small few lines recommendation and they leave, and we don't know if they're coming next day. So it's okay. We are doctors too. We should be able to do our things. We don't need consultation or everything. But what bothers me is many things you have to do as a primary attending is the administration pressure to discharge a patient. Length of stay, like quality incentives before stay. Then again, you have to discharge the patient with a short hospital stay. But then again, you cannot have readmission. That's okay too. But I feel it can be overwhelming, especially in our hospital where we work. It's more like different kind of patient population, very demanding patient population, and a lot of things like palliative, moles, emols. Like I feel like sometimes we work 7 on 7 off, so the schedule is good, money is good, but the 7 days that you work in can be stressful. Some days, not every day. I mean, I think I'm good at it, but I feel like I can do better as a fellow. So why I chose this specialty? I actually went to our hospital because I was very interested in GI. So when I uh, went to this hospital, our hospital started into like the GI fellowship. They had good, strong interventional GI, and they give you mentor on your day one as a PGY1. So I chose the GI doctor, and I was involved in some research. After doing few months, I thought it's not really something that I want. It is something that I thought would be nice, but not for me. There are many reasons, like more interventions and other things. So then I was very interested in cardio. 2 years, I really worked on cardio. I had some papers published in cardio, and but there were some family things going on. So I thought that 2 more years. So if I was in Dhaka Medical College. I graduated from Dhaka Medical College. Then I came in, lots of stories. Then I went to NICOM again. I did DO. So I spent some time. So I thought, okay, fellowship, maybe it's time to earn some money, live some life at least at this time. So I did that. But endocrine is another thing that I liked. I did some elective as well when I was doing, because endocrine was also in the back of my mind, because cardio is very, very competitive fellowship. And if you are thinking I may or may not do, cardio doesn't work that way. You really have to be committed. You have to have your fellowships, GI, cardio, everything is very, very competitive. Endocrine is less competitive, in that way, but it's also competitive. But when I was doing hospitals, so networking helps you a big way. Networking, connections, so thankfully I have very good connections with my mentors, who are my mentors now, my colleagues. So one of my nephrology friend is Dr. Pinkasap. So he actually texted me and he said, hey, Ashik, there is a fellowship they're starting at Brookdale. And I know you're interested in endocrine. You're planning to apply this year. So I was planning to apply in July and then go. He said, why don't you try? I said, yeah, I'll try. I have a very busy day. I will try. I was not serious because it was not in my mind, but I was planning to work on endocrine. So I was getting my papers ready. He said, just give it a try. And then he reminded me again after 1 week, did you apply? He got me the phone number. So to make him happy, I said, okay, I will call. So I called, I emailed, and then Brookdale, and then they had initially they filled up. Then I think one applicant left for some reason. So they said, we are re-interviewing, you can come in. I said, okay, I'll come in. I took a day off. I went there. Not much preparation. No, I don't care because I have a job. It doesn't matter. So I think it was better for me. So I was there, went in. But again, be confident, be humble. There are all the doctors there. So there's the person who I am not very comfortable with, Dr. Fisher, from my early days. So I see him meet him in person. But they did an in-person interview. Nice people. I think they liked on the spot. They told me there right away. I said yes, and then I came in. That's how I'm starting. Just an off cycle. It's starting right now. But endocrine is something like I also worked as a diabetic coordinator, like a health educator. So I work with many patients with diabetes. While I was working as a care coordinator, network relations from MetroPlus Health Plan before going to NICOM. So that's another area where I got used to this thing, and I feel like I like the work-life balance is a big thing. The salary is not that much. If you only do only the endocrine, then it's not that high, but you can do a lot of things. The demand is high, the work-life balance is good, and you can also do some shifts as hospitalized. So that was the reason I'm going into. Also, it's not 3 years; it's 2 years. That's another reason. Yeah, but it can change. We can go into like thinking in the back of our head, like we will do this fellowship on my day one. Some are so committed, and they really like that. You have to do something that you like it. Just not for the thing that sounds good, like cardio surgery, something that you really like and you feel comfortable with and you want to do it. Only then spending the 2 3 extra years for the thing helps, because now you'll be practicing that will be your livelihood. So yeah, well, I think something having in your mind helps. Then you can get connected with other people, have research back. Whatever research you do, that will help. But then as you move forward, you may like another subject. That's okay, because now we are exploring and we are learning more. That's okay. But figuring out things earlier helps you. So you can build your CV that way and you can do better. Okay.
Another question. So, যদি কেউ থাকে যে already residency তে ঢুকে, they kind of have an idea about that they want to go into fellowship and they want to go into this specific specialty. Is there any way that they can like modify their schedule where they can spend more time as a resident on that specialty and then less time on others, or it's like a very fixed schedule and residency that you can't do that?
So I can give you my thought. Also, Dr. Malik, she's also on one of the chiefs. So I think we can tell. Like I feel like when I was an assistant chief, we did not have third year chief. So we had fourth year chief and third year assistant chief. So they told me to be fourth year. I did not become. I said no, I need one. I need job. I need money. So, anyways, as a chief president, as a program director, we try to accommodate those based on their goals. So you will learn many of us asking, "What do you want to do?" Many ways. Some say, no, I want outpatient, I want inpatient. Someone, no, I want to do fellowship. Most of the people want to talk about fellowship early days. So we try to accommodate those. In our hospital, we also try to help them get those elective rotations. So ours is Mount Sinai South now, so they have 8, 9 hospitals in the city. So we try to, connect them to the hospital in the city to have the elective rotation, to have more exposure, not in one hospital. Also, we try to do those earlier in a favorable time, where they want us to do. So you have to make a plan when you want to take your step 3. That's why it's very important to have the step 3 done by the end of first year. So now you can focus learning and scheduling, because you have to apply at the end of your second year, I think, for the fellowship, right? The July. So you need your LOR by that time. The only way to have the LOR is having the rotations done beforehand. So they will be helpful. They will be very helpful, but you have to be very clear. I want to do this, I want to do, because if all of you want to do the fellowship, all of you want to have rotation at the same time, it's not possible, but it can be arranged. It can be accommodated. Yeah.
So this is like an open question. I'm sorry. I know that I'm asking a lot of
I just
questions.
want
It's
to
just
add
that,
on the fellowship. I just want to add on the
yeah.
fellowship. Yeah, like as Dr. Ashik mentioned, that you have like the electives will be managed and all, but a lot of times, like for example, my program, I would say it's a community program. A lot of us do end up in a community program, and we don't have like enough research time, a rotation for research or rotation for. We have electives, but when you think of like competitive fellowships like GI, HEMONC, cardio, you need to actually spend a lot of your personal time on research, give your weekends up for research. Like it's just that kind of competition going on. Specifically, and this is the harsh reality that, there won't be if you're actually, it's a harsh reality of a community-based program. It's not bad. It's how it is structured that, you are expected to just, your entire curriculum is more to prepare you as a hospitalist, but not, not for, doing research and, publishing, and they don't support always a lot of times, but just having that in the back of your head that if you're actually applying for a competitive fellowship, you need to also push yourself and take out your own personal time to do the researches for those.
Oh, thank you so much for adding that. This is like an open question. So, Jerome, like, I think it's kind of obvious that I am interested in fellowship. That's why I have so many questions about fellowship, but I'm just so confused about which fellowship I want to go into with, because the options are like, at this point, it feels like it's like insane. Like there's too many options to choose from. So I do know that, so like getting step 3 done like earlier is definitely a plus. So I do like, so what I want to ask is that I know that the residency have like really long hours. So how do you like perform well during your residency? At the same time, you have time to prepare for your boards, and at the same time, you're also kind of thinking about adding like research. But like, how do you allocate time like that? Like, because residency is, it's like always very like go go go, and you don't have like those time where you can kind of take out like an hour or two and you can kind of study for the boards. Like, is it not like that? Like, how do you allocate time for everything that you have on your plate?
So, first year is mostly, in our hospital at least, the first year is very inpatient heavy, most of the PGY places, where initial first 6 months, you really do not have much time to study. So again, as I said, surviving, organizing, then last 6 months, you can really have things done like step exams, if you can. If you have that, if you have not done it, that's fine. But when in PGY2, again, having a plan is very important, like a timeline. And based on that timeline, asking your program director chiefs to have their schedule. So now see, somebody who have not taken a step, they may need some time, easy rotation before that exam, right? Some people who already took the exam, they may ask for an elective. It could be a research elective to really work on research, or an outside rotation if the program permits. So planning ahead, having that organized plan and trying to do that is very important, I think. If you're working in a community program, then try to see which the upper class before you, where did they match mostly, where did they not match at all. That will give you some idea. Why? Ask them like why it is happening too. If not, from some program, maybe nobody matched to cardio, but you want cardio. In that case, I will say you have to work even harder, because harder means when you don't have inpatient, when you're done with your exam or not done with your exam. So on your like during an outpatient rotation, weekends or on electives, you have to come to the hospital, work on your papers, maybe multiple papers at the same time, diverse it, case report, research. If you have the research support, good, not good, have a good mentor with you, who is a little bit more oriented about where to submit the papers, which conferences to send the patient to, and some inside your hospital. So more you have, it's better. And if you have something published, that is good. But from a community program to match to a highly competitive specialty is a little bit difficult, but not impossible. You have to apply. We have done impossible things, right, in this country, so we can do. So we have to apply in a broader way, and we have to apply in a broader way. And I will say another thing is, when you apply for fellowship, if you're really interested in fellowship, also apply a second fellowship too, that you also like. Maybe if you don't like anything, then you just apply broad and work as an attending or something, or you can, if somebody looks for fourth tier chief, you can do as fourth tier chief. And but if you do those things, then you have to do those things, better to do those things in a hospital, in a university hospital where they have those fellowships, then that can give you one extra level, may or may not help. But that's the way to go, I think. Planning, organization, giving extra time, committing to it, and then you go from there. Attending the conferences, some places, and then make some connections. Connections is important too. Yeah.
Thank you so much. Dr. Mushin, would you like to add something?
No, I think Dr. Ashik mentioned a lot, everything. But just, I feel like, when just for, I know there's a lot of things to do, and you need to find your own time. But there's few things, of course, which are important for a fellowship. One is your research. One is your visa status. One is your communications. I think that these are core things which are very important when you are applying for a fellowship, specifically the competitive ones. Of course, you can't change your visa status. That will be your connections and your research you can work on. For the research purposes, of course, you can do courses, as I said, like I have done Catalyst course and doing NIS-based data analysis. I have taken systematic reviews courses, and I did, like, as I said, I spent a lot of my weekends on just doing these kind of things, but that's what I wanted to do. So you have to dedicate time like that, and then of course, very important, I feel, is a mentorship. If you have a good mentor, that that person will actually guide you very well. Now, of course, you can go to conferences to make, and find mentors. But there are also like every community, like for example, cardiology has its ACC has mentorship, like you can find mentors in ACC if you go to their website. Also ACG has their own mentorship program going on. You can find mentors through the website. Also, like if you are a part of, for example, women in cardiology, if you're a part of that, you can find women mentors, and then they can actually help you guide what needs to be done. And I think if you have that kind of supervision, you have a better understanding of how to get things done. Also, like it's very important, if you're in a program and in that in your residency program, find people who are applying for the same fellowship. I really feel they are not only your competitions, but they're also your peers. And if you work collectively, you can get more research published together than just working alone. So try to find like-minded people, and then you can get stuff's done faster. If we are 4 or 3 people and 3 people are working on 3 different abstracts, and submitting it alone compared to 3 abstracts being submitted to ACC, there are more chances of you having a poster presented. So working like that will, I feel, help. That's how I'm approaching.
Thank you. Really, really good advices. So, like, I felt like that fellowship isn't something that I can actually do, but I do feel like something that, like, I was discouraged about it, but then I definitely feel like this is something that I should not give up on. So thank you for that. And with that, we are going at the end of our webinar. I will hand it over to Dr. Rahana to close everything up. Thank you to both of you for your valuable advices and to share your experiences. I feel very humbled, but at the same time, very encouraged. Thank you.
Thank you, Dr. Anika. And thank you so much, Dr. Ashik, Dr. Mushin Malik Apu, Dr. Farhan Akhtar, for your valuable suggestions, advices, tips, and tricks. I believe that this is going to help the incoming PGY1 residents and also the applicant who will be applying next year, and also the people, the other people who are studying for USMLE and also want to pursue this journey. And also, you guys mentioned about the networking, work collectively, the resources, and the proper sign out, patient focused study, and active participation, and most importantly, work in a team. I believe that we all will work on these things, and that will make all of us stand out and proper, and also that will help us to be a good physician. Yeah, so I congratulations again all of the incoming PGY1, and I believe that you guys all will do great, and you guys will make us proud. And I want to especially thanks to Dr. Masood for organizing this amazing event for us. And thanks to all our panelists again for sharing with us their valuable suggestion advices. And I would like to invite you all to join us for next webinar on next weekend. Thank you all for participating. You guys have a very, very wonderful and blessed day. Thank you.